All right, now we've learned about endocrinology. We're going to move on to hematology, the study of the blood system and blood, and basically this PowerPoint's going to be on anemias and clotting disorders. So let's look at the normal before we look at the abnormal. Bone marrow, every blood cell, not every, but most blood cells for red blood cell production, white blood cell production, and platelets are made in the bone marrow. It's a blood cell factory, highly vascularized as soon as the stem cells divide into their respective parts. You get red blood cells, white blood cells, and platelets all made in the bone marrow. The spleen is used to kind of as a storage facility and a cleanup facility. It stores red blood cells and platelets until they're needed in circulation. Can hold up to about 300 cc's of blood or milliliters of blood. We don't need a spleen. Spleens can be removed, but when a spleen is removed, you don't have as much storage room, and so everything's out in the circulation. It's just an extra cleaning facility that kind of goes along with the liver in terms of storing and filtering. But like I said, we can live without it, and many people have their spleens removed for traumatic reasons, and they get along perfectly fine. It just means that you don't store red and white blood cells and platelets out of the circulation. And it is actually a treatment for many disorders to remove some of the sequestered old bad blood products when we have an issue with making bad blood products. So the spleen, not necessary, nice to have, not a need to have. The liver is important, as we learned, and it creates most of our clotting cascade coagulation factors, stores vitamin K, and that's going to be an issue when we have some clotting disorders. So we'll bring the liver back into play. But let's just talk about kind of what our blood cells are made of. Made out of plasma and the actual blood cells. The actual blood cells are white blood cells, red blood cells, and platelets. And then we have our plasma, so that the red blood cells, white blood cells, and platelets make up our formed elements. And then our plasma is water, protein, and all the other things that we carry around in our bloodstream. So that's just a little bit of a summary there. Let's talk about our red blood cells first. What's normal about red blood cells is that they are formed to carry oxygen and carbon dioxide. That's their job. Oxygen and carbon dioxide are carried on hemoglobin molecules, and they need iron to attach the oxygen and the carbon dioxide to the hemoglobin molecule. So you need hemoglobin to carry oxygen. Only mature red blood cells can carry oxygen. Mature red blood cells have a fully grown hemoglobin with 4 spots to add on to, and iron is needed to create the site of oxygen binding. Just some vocabulary words. If you hear the word erythro, anything erythro involves your red blood cells. Erythro, anything, means red blood cells. So if you don't even know what the beginning, if it's erythro, it has something to do with your red blood cells. Erythropoiesis means production of red blood cells. You know that is due to erythropoietin, which is released by the kidney, and that stimulates red blood cell production. Reticulocytes are baby red blood cells, so they have a big long name, but they are tiny red blood cells, and immature reticulocytes cannot carry oxygen yet. They don't have fully developed hemoglobins and do not have the iron binding sites. And then lysis of anything means breaking up, so hemolysis is breaking up of red blood cells. Should be erythrolysis, but maybe it was too hard to say. So anyway, when you break up a red blood cell, it releases bilirubin, and that goes as a waste product, and all the other components get broken up to remake new blood cells. And blood cells on their own live for 120 days, which is about 3 or 4 months. And that is why those hemoglobin A1Cs are a picture of your long-term insulin control, because it's a picture of what your sugar looked like 3 months ago when that hemoglobin molecule was made. But hemoglobin lives for those red blood cells live programmed for about 120 days, and then they they self-destruct, basically. So that's red blood cells. White blood cells are called leukocytes. So leuko, anything, is white blood cells. There are a bunch of different kinds. Really, anything other than lymphocytes is considered a first line of defense. You do not need to know what all the different kinds are. But if it's a lymphocyte, those are the second line of defense in turn. They kind of manage antibody production, long-term memory of a foreign substance, specific immunity. Those are your B lymphocytes and your T lymphocytes. Those go off onto like a special school to learn how to recognize certain antigens and are kept around for specific immunity. And the T lymphocytes can also create more of themselves. So if you have a vaccine, those work with your B and T lymphocytes to create immunity. The other ones are just find and kill sort of cells. First line of defense, and then you have your second line of defense, your backup white blood cells. Very basic. I could probably spend an entire semester on just white blood cells, so we're just going to stay basic there. Platelets are platelets, and they are there for your first line of defense to plug a hole. Platelets are creating a platelet plug and are your first line of defense in solving bleeding problems. So they bind to any damaged vessel or any damaged area and cause a quick plug. And platelets are the size of a plate. They look like the little round guys. This is in their unactive, so this is their unactivated phase. So they get activated. If they're unactivated, they're just rolling around like little plates, and the reason they kind of roll around like plates is things bounce off of them. But then these are activated platelets, and activated platelets look like little kind of octopi. They're activated by a damaged blood vessel sends out a signal, and as the signal hits the platelets activate and turn into these sticky spider-looking things with tentacles that adhere to each other and create a plug over that site. So only the localized site is supposed to react, is supposed to create this this activation of platelets, and the platelets just kind of stick right there to where they're activated. Once they're activated, they are useless. They're no longer, once they've created a platelet plug, they have to be destroyed. Activated platelets can't unactivate again and become a plate form. Once they've popped open like a pufferfish, they are active, and then they are destroyed after their use is over. They're a one-time use item, platelets are. Otherwise, if they're just roaming around like little plates and never get activated, they live about 8 to 11 days. But once they are activated, they are removed from the blood circulation by your system. So that's our three major blood cells, red blood cells, white blood cells, and platelets. And then we have plasma, which is everything else. This is where our protein, the albumins, get carried. Any extra things that are being carried around, waste products on their way back to the liver and to the kidney to get excreted, or going back to the intestines, anything that's being carried around for use. Glucose would be in here. This is not by all means all that's in the plasma, but that's what's in the plasma. Clotting factors are carried in the plasma. Antibodies, I don't even know what that was trying to say. Produced by, I guess antibodies are produced by plasma cells. Anyway, that's just everything of what's in the plasma. Let's talk a little bit about clot formation. This is part of normal process. Because we are going to talk about clotting disorders, we need to know how a clot happens. I'm going to show you that clots happen on a twofold path. This is your first, this damaged tissue sets two things in motion. This is your first line of clotting, and that is your platelets. Your platelets create a platelet plug, and that kind of plugs up the hole until the rest of the system can lay down this mesh and then kind of cover up those activated platelets with a mesh of actual clot. So when you are holding a pressure on a bleeding site. The platelet plug may form first, but it's not going to be firm and solid. It's basically these two clotting cascades, which I'm not going to make you memorize. Just know that there are two clotting cascades, intrinsic and extrinsic, which I'll show you in a minute. Both cascades activate thrombin, which turns into fibrin and creates a fibrin clot. So this is very, very fancy, but I did want to show you that you have two anticoagulants, really. One is known as an antiplatelet. So, sorry, not everything works in the same parts of the system. If you have antiplatelets, which are aspirin, Plavix, so double check when you have an anticoagulant. Is it an antiplatelet or is it an anticoagulant? Because antiplatelets work in the first line of defense, but do not do anything to affect your clotting cascade. Your anticoagulants here are actually what affects your clotting cascade, and they work on thrombin. So I do want to point out that if you are taking an antiplatelet, you're not going to affect your clotting cascades, and if you're taking an anticoagulant, it's not going to affect your platelets at all. They are two different systems, and they have two different medications to work on those systems. Now, if you're on an antiplatelet and an anticoagulant, now you've got multiple issues with clot formation. So again, just repeating, the first stage is a platelet plug. The first stage of clotting is a platelet plug. The damaged vessel sends out the signal. The platelets activate. They start sticking to one another, and they create a little plug. Once the hole has been plugged up, that damage signal kind of goes away and stops activating platelets nearby. The second stage, though, was activated by that blood vessel sending out a signal, and those are the coagulation cascades. The important thing to remember about the coagulation cascades is the two different kinds, intrinsic and extrinsic. And intrinsic is measured by your PTT, your partial thromboplastin time. So that is measured by one coagulation factor, and your extrinsic pathway is measured by your prothrombin time. So now you can kind of see that when we start using anticoagulants, certain anticoagulants work in one pathway and certain anticoagulants work in another pathway. So again, this is a very complex process, and I'm trying to simplify it. But when we are looking at whether we're worried about our platelets, we're going to be looking at a platelet level. When we are taking antiplatelets like aspirin or Plavix, you are not going to see a change to your PT or your PTT because aspirins and Plavix and antiplatelets do not work in that cycle. So this is measured. If we want to measure this leg of our clotting cascade, we would need to look at our platelet function. And if we want to measure this part of our cascade, we will look at our PT and PTT. The PT goes with the extrinsic and the PTT goes with the intrinsic. And again, that's just general. I just want you to know that if you're taking an aspirin and you're looking for a change in your PT-PTT, it's probably not going to do anything. If you're taking heparin, it's not going to affect your platelets. It's going to affect your clotting cascade. So, very basic. Platelet plug, fibrin clot. And then after a clot has formed and repair has been done, this is kind of like closing off, a lane of the highway while they're doing repairs. Once that's all done, you got to clean up the mess there. And our body, you've probably heard of TPA or streptokinase. Tissue plasminogen activator is our own body's clot buster. TPA we can make and we can give, but it is a clot buster and it will break up clots. That's its whole job. Anticoagulants just inhibit the formation of that fibrin mesh, but TPA actually breaks down fibrin meshes and breaks down clots. So TPA and streptokinase are our only plasminogen activators. They're our only thing that activates the breakdown of clots. So that is the only thing that is considered a clot buster. Anticoagulants are given to clots to prevent that clot from getting bigger and inhibiting and preventing this thing from getting bigger, but nothing, it won't break it down. It allows, anticoagulants will allow that clot to not get bigger until our own TPA can go and break it down. We save TPA for high risk clots like pulmonary embolus or massive MIs where you can't go in and do a cath lab procedure. TPA has a lot of risk factors with it. We need to let our own body break up our own clots. Like I said, if you give somebody a high dose of TPA that we would for an emergency clot, it will release all the fibrin meshes in the whole body, including anything that maybe would have formed in your brain or anything that may have formed somewhere in your circulation. We're constantly breaking little pieces of our vessels and fixing things up, and TPA will break all of that up. So we have a normal level of TPA in our body that circulates around to clean up clots. But when TPA does break up clots, it creates basically some fibrin degradation products, fibrin split products, and something called a D-dimer. And those are just basically when the clot is being broken up. So we can measure those to see if we have a lot of clotting going on in our body, because if we have a lot of fibrin split products, fibrin degradation products, or a high D-dimer, that means that our body is breaking up a lot of clots on its own. So let's look at our lab work a little bit. You probably know what's in a CBC, but just to double check, it comes with a white blood cell, red blood cell count, hemoglobin, hematocrit, platelet count, and then a differential is each type of white blood cell and its percentage. So that's what a complete blood count entails. You may see these little fishbone things up there. Those are just standard ways that people kind of communicate. You may see people just write numbers in their fishbones. So if you see, and they're just called, they're called fishbones, but if you draw this and just write numbers in there, and you write, you're writing in, oops, I didn't mean to write that. I was trying to write a fishbone there. But you'll just see people, you won't write the names in there. It's just kind of a standardized way to, you may see nurses have these on their brain sheets or something like that, or take report and get brain sheets. And, as they get these values, they'll write them in there just like that. It's a standard form. You don't have to memorize it. It's just kind of nice to know when you see something like that on someone's report sheet. And there's a standardized one for PT, PTT, and then INR goes in the corner. So that's the CBC, the red blood cells. There are some extra tests that we do around when you have less than adequate red blood cell production. As soon as you see a decrease in your red blood cells, hemoglobin, hematocrit, they'll probably run all the rest of these tests there. Iron level, total iron binding capacity, that's basically how many iron spots do you have to bind oxygen. Ferritin is another iron level, erythropoietin, do you have something stimulating your red blood cells, and bilirubin is breakdown of red blood cells. Coag studies are clotting times. PT and PTT and INR or PT and PTT are physically in seconds. That is a physical clotting time, the time that it takes your intrinsic and extrinsic cascade to create a fibrin mesh clot. So a PT is measuring how long it takes that extrinsic cascade to make a clot. PTT is how long it takes the intrinsic cascade to make a clot. INR is, I'm not really entirely sure, and INR goes with a PT, and don't ask me to really explain what an INR reads because I'm not exactly sure, but it goes with PT. It does not have any, it goes with the extrinsic cascade. It doesn't have anything to do with the PTT. PT and INR go together. The activated clotting time is a physical whole clotting time, and then fibrinogen, D-dimer, fibrin degradation products, and fibrin split products are fibrin breakdown products. So again, this is just, written out all the different things, what they are. In terms of what do you need to study and remember, The important numbers that I would like you to remember would probably be your white blood cells to know, and this is, you know, I hate every single lab has a different number, but I'd like you to know that, you know, what is super low. And, you know, if I'm going to give you a low white blood cell, we're going to say from 1 to 4 is going to be low. You can even say 4 to 10. You could say, and again, I don't even remember which source. I think I got this from the Evolve Elsevier book. So your Lippincott book might be slightly different. But again, I'm not going to give you 5 and tell you it's low. I'm going to give you low white blood cells would be 1, 2, 3, 4. High white blood cells will be in the upper teens to 20s. You know, I'm not going to quibble over close numbers, but you would like to know what a low white blood cell and a high white blood cell are. You probably know your hemoglobin hematocrit. The big number to remember on hemoglobin is less than 7 because we don't transfuse anything less than 7. But anywhere from 7 to 10 is starting to be kind of a low hemoglobin. Hematocrit, again, it also depends on whether you're a man, whether you're a woman. I would just like you to know the worrisome trends on it, and I would say less than 4 of white blood cells, greater than 10 white blood cells. That's probably not, let me just clean this all up. Let's say that I would want you to remember that less than 4 is bad, greater than 10 is probably not great. Hemoglobin less than 7 is worrisome, and a hematocrit, probably don't really quite go with that, you know, but I don't know, 30 to 50 is probably a good range. Anything less than 30, more than 50, let's say. Just for general, and NCLEX is not going to do something crazy to you as well. If they tell you your hemoglobin is 6.8 and 20, you need to know that you recognize that as low. We're not too concerned about high hemoglobin hematocrits. It doesn't usually happen too much unless you're really concentrated. But again, knowing a hemoglobin less than 7 is dangerous. Less than 10 is starting to get, you know, we better watch it. That's probably where we want to be. A platelet count, let's just go with less than 150 is worrisome. So, I don't even think we need to worry about big numbers. I would say less than 7, less than 30, less than 150, and less than 4. Those would be kind of a good guesstimate to remember on your CBC. In terms of your PTT, no, I would probably give you regulars on these. Anything elevated or prolonged is going to be a concern for yours. A short PTT isn't really a big finding, but we would want to know about prolonged ones. So, you know, something longer than 12 seconds, something longer than, you know, 45 seconds. I'd probably even make it longer than that. I'd give you a PTT of, you know, 55 or something really long. And really what you can imagine is if you have a little bleeder, you pull out an IV and you hold it. If you're holding it for about 45 seconds, you'll probably have enough time for your PT and your PTT to work and for that clot to form. The INR, we usually only look at that when you are giving an anticoagulant, which is Coumadin, which works in the PT section, and I would want you to know 2 to 3.5 for that. We want to keep it right within that INR range. The rest of them, just kind of recognize them for what they are. I'm not going to test you on them. Vocabulary, again, this is just so that if I'm using these words in a test question, or if you see these words, you know what they mean. Pancytopenia means everything. Pan means all. So pancytopenia means everything is low, because penia means low. All values in your CBC are low. Anemia means low red blood cells. Leukopenia means low white blood cells. Neutropenia is a specific white blood cell that is low. Reticulocyte, again, is an immature red blood cell. Thrombocytopenia means low platelets, and thrombocytosis is excessive platelets. You can have leukocytosis, which means excessive white blood cells. Erythrocytosis, meaning excessive. So just kind of getting to know those words, those terminologies, so that if you see them, you recognize them. Probably when you do questions, you'll start getting to know these. Go back to your vocabulary list. Again, skin assessment is really what we're looking for, is for hematology-wise. Small petechiae. Petechiae are itty-bitty little collections of blood vessels. Purpura is a rash of spots, and a bruise is a bruise. Spider nevi are a collection of small dilated arterioles. Those actually go more with, those are estrogen related. They're not really hematology related. Those are a sign of estrogen over excessive estrogen deposits. Clubbing is a sign of chronic low oxygen. Pale and cyanosis can be a sign of anemia. Again, just general assessment terms. So let's talk about the anemias. Anemias. Disorder of red blood cells. There are 4 kinds of anemias. You are going to know all 4 kinds. Well, really the 3 kinds. Blood loss is blood loss. There are 2 kinds of microcytic, meaning making itty-bitty, small, pale red blood cells. Micro, meaning small. Microcytic anemia, they're small, pale red blood cells. And macrocytic are large, useless red blood cells, really. They're both useless. They're pale. The small ones are pale because they can't carry oxygen, and the large ones are basically, they can't carry oxygen either, and we'll kind of go through why, the reasons for those. But the 2 microcytic anemias are iron deficiency anemia and thalassemia. That's embarrassing. Can't even say it. Thalassemia? I'm just going to go with that. Macrocytic anemia is cobalamin or B12 deficiency and folic acid deficiency. So macrocytic anemias are when you don't have the proper nutrients to mature your red blood cells. And then we have hemolytic anemias, which are lysing and destroyed red blood cells. So all anemias, all problems with red blood cells have hypoxia signs and symptoms, because red blood cells carry oxygen, and when we have dysfunctional red blood cells, we're not carrying oxygen to our full capacity. Just having anemias can give you pale skin, pale conjunctivitis and sclera. So if you pull down your eyelid and look at your eyelid, if it's nice and red, that's a good sign. If it's pale and almost white under your eyelid, that could be a sign of anemia. Clubbing of nail beds, so the more clubbed your nail beds are, the more chronic your hypoxia is. Increased heart rate and increased respiratory rate, because you're not getting the normal amounts of oxygen the body's used to, and so it speeds up your heart rate, trying to circulate more oxygen and get more oxygen around. Increased respiratory rate, because you're trying to exchange more oxygen. Easy fatigue, loss of energy, because oxygen is our energy source, how we create energy. Headache, irritability, difficulty concentrating, dizziness are just lack of oxygen to the brain. And anorexia, constipation, gastric slowing, because if you don't have enough oxygen, your gastric system can't do what it's supposed to do. So that's just kind of having an anemia. As your anemia gets worse and worse, you end up, you can get shortness of breath, which is actually, you have so low red blood cells, you really can't carry oxygen to the point that you're getting short of breath. Your headache and irritability can turn into confusion, lethargy, decreased level of consciousness. That's less and less oxygen going to the brain. Chest pain, arrhythmias is a lack of oxygen to the heart. And numbness, tingling in lips and extremities is lack of oxygen to the extremities. And you can get muscle cramps because when you don't have enough oxygen, your body will create energy an inefficient way. It would rather create energy from oxygen. I don't know if you remember back to the Krebs cycle in high school biology, but your body wants to create energy using oxygen. If it doesn't have enough oxygen, it will create energy using an anaerobic process, which is non-oxygen, but it creates lactic acid in the process. So whenever you have an increased lactate or increased lactic acid level, you are having hypoxia of some kind, a decreased oxygen level. So with all anemias, all deficiencies of red blood cells, no matter the kind, our big concern is, are we carrying enough oxygen? These are our signs and symptoms of whether we're carrying enough oxygen or not to our body. Of course, the key assessments for anemias is oxygenation, your oxygen stat, heart rate. I'll let you read the list. We'll be looking at CBCs and iron levels as well for most anemias, but we'll be explaining the differences between all of them here. So let's talk about our first one, the iron deficiency anemia. It's due to a lack of iron, and so the hemoglobin cannot connect to the 4 oxygens it's supposed to. You don't have enough iron in there to create a good hemoglobin molecule that can be efficient at carrying oxygen. So you might have a low hemoglobin hematocrit and a low red blood cell count. When they do a smear of them and look at them, they can see they are small, pale red blood cells. They have a low iron level and a low total iron binding capacity. So the intervention is to give them iron. If you have not been getting enough iron in your diet, you can take oral iron supplements and a diet rich in iron. If you can't absorb iron because you have something wrong with your duodenum, which is where it's absorbed, or your GI function, they can give iron IM or IV. And just know that if you're giving iron, it can stain the skin if you're giving it IM, so you have to give it Z-Track. They're iron-rich foods. Like I said, most of it is dietary intake, malnutrition, blood loss. And so if you do need to beef up your iron, iron-rich foods are a great way to do it. They're listed over there. You know, the broccoli, spinach, red meats, eggs, great foods for iron. You can take oral iron. Just if you're taking oral iron, it is absorbed in the duodenum. So if you're being sold enteric-coated iron, it's a scam. Don't buy it. Doesn't work. It's best absorbed in an acidic environment, so take it with vitamin C. A lot of iron comes with vitamin C, but if you get plain old iron, vitamin C, drinking an orange juice with it or something would be best for it. It enhances absorption. It's supposed to be given 3 to 4 times a day, an hour before meals, because it's better in an acidic environment before food gets in there and buffers the acid. So an acidic is more acidic prior to meals. Liquid iron stains teeth just like IV iron stains the skin, so drink it through a straw. If you are unable to absorb it in the duodenum, maybe you lost your duodenum, maybe you have Crohn's disease. If you can't absorb iron in the duodenum, then you get IV or IM iron. So iron deficiency anemia, give iron. Easy enough, right? Thalassemia is a genetic disease. You can't make a normal hemoglobin module. There's problems with the protein folding, and it can't carry adequate amounts of oxygen. They will have a low hemoglobin hematocrit, low white blood cell count, small, pale red blood cells, but they have normal iron and normal total iron binding capacity. They have to do a genetic test, genetic screening. If you do have an anemia and they have microcytic pale red blood cells and you have normal iron levels, then they will start screening you for thalassemia. I do believe it's in one of the newborn screens. Minor thalassemia, you just get used to the lower oxygen carrying capacity, and the body adapts by making more red blood cells that carry less oxygen, but you have more red blood cells, so it all works out even, and there are no real treatments for that one. Thalassemia major is something where you can have physical and mental growth retarded because of the lack of oxygen capacity. the only cure is stem cell transplant, because you can't make your genetic code for red blood cell as bad. So you would have to replace your stem cells in your bone marrow with red blood cell stem cells that are not coded wrong. And so stem cell transplant is the only cure. And until they get a stem cell transplant, they might need blood transfusions to get adequate oxygen carrying capacity. And you could do a splenectomy. Splenectomies are on the table for any hematology disease because it decreases the storage of the diseased red blood cells. If you want to replace them, you don't want the bad ones stored somewhere. You get rid of the whole storage facility, and you can't store the bad ones. But again, it is genetic. Genetic counseling is the key for genetic diseases. No specific drug or diet works. You want them to have as well of a diet as you can, and reduce your workload, cluster the care, and allow a lot of rest periods, and make sure they don't get sick and create more problems for themselves, because whenever you're sick you have increased oxygen requirements. So avoiding any kind of illness would be good for thalassemia. But again, that red blood cell disorder we have to do a bone marrow transplant for. So let's talk about our big ones. Those were our tiny, small bill ones. Iron deficiency, great, take iron. Thalassemia, genetic counseling, stem cell transplant. Those are the two microcytic blood anemias. Now we have the macrocytic anemias, which is basically we have a deficiency in the vitamins that are needed to mature a red blood cell to oxygen carrying capacity. So vitamin B12 is your first one. Vitamin B12 is complex in that you just don't absorb it by itself. B12 has to join up with something called intrinsic factor, which is made by your gastric cells. So intrinsic factor is made by gastric cells. It binds B12 in the stomach, and then that complex is absorbed later on in the intestine, in the ileum. So if you do not have good gastric cells creating intrinsic factor, then you cannot absorb. The receptors in the ileum don't recognize B12 without intrinsic factor attached to it. So you won't absorb B12 even if you eat a ton of it if you have problems with intrinsic factor. So the specific cues of that, of course, we have all of our hypoxia signs and symptoms that we had on the first page, but additional cues for deficiency. B12 has neuromuscular manifestations, tingling, pins, needle sensation in the hands and the feet, because B12 is also used in nerve function. So if you're deficient on it, you have some nerve dysfunction, stiffness of the legs, just difficulty transmitting and sensing from the nerves. You also have oral mucosa is involved with B12, and so they get a sore, red, beefy, shiny tongue with less, what's the word? They're very sore. Lots of sore ulcers in the around the lips, the tongue, the oral mucosa, lots of mouth sores, and like I said, this sore tongue. It's almost like when you burn your tongue on a hot drink, just that sore red tongue. Lots of pain in the mouth there. So those are specific with B12, the neuromuscular and the mouth ulcers and mouth sores, low red blood cells, low hematocrit, hemoglobin, high baby red blood cell count. Because again, this is used for red blood cell maturation. There's not enough red blood cells circulating around that's carrying oxygen, so the kidney says make more. They make more, but they can't mature. So lots of immature red blood cells. The cells become large, but large and red, but they're not carrying oxygen. The B12 is used to create that hemoglobin molecule that carries 4 oxygens, and it is not being formed properly. So even though the cells are large and not pale, they are still not carrying oxygen, and the key is a low B12 level. So you're going to draw your iron levels, they're all good. You draw your total iron binding capacity, they're all good. Look at the red blood cells, they're large, and the B12 count is low. They'll also do an intrinsic factor test, which will test whether your stomach is actually making intrinsic factor or not, to decide Are you just low in your diet of B12? And if you're making intrinsic factor, you can have oral B12. If you're not making intrinsic factor, you'll have to have B12 another way because it'll never get digested, no matter how many pills you take. So the treatment is based on the cause of the deficiency. If it's just not bad nourishment or cirrhosis can't hold B12, your liver can't hold your B12, then you could take oral or sublingual B12 supplements. Diet rich in B12. B12 is great in milk, nuts, and eggs and chicken. So B12 is great. Red meats are great. So red meats are great for anybody with a iron deficiency. But if you have a vegetarian with a B12 or iron deficiency, then probably the nuts would be the best way to go. So if you're just malnourished, eat tons of B12, take B12 supplements, and you'll be fine. If you cannot absorb B12 because you have a lack of intrinsic factor, and a lack of intrinsic factor is known as pernicious anemia. I do believe I wrote that somewhere. Maybe not. If you see the word pernicious anemia, that just means a lack of intrinsic factor. It is a B12 deficiency, pernicious anemia. It's just one of the sources of B12 deficiency. So pernicious anemia just means a lack of intrinsic factor. If your stomach is not making intrinsic factor, you could eat 5, 6, 7 B12 tablets and they'll still not get absorbed because the ileum won't recognize it if B12 is not bound to intrinsic factor. You can also have a disorder of your ileum, Crohn's disease, or maybe a small bowel obstruction in that area. If you have some problems with your ileum, then you can take 18-12. You can have tons of intrinsic factor. You can take 18 pills, and it all binds to intrinsic factor, but the ileum can't absorb it. So if you have malabsorption of B12, then you'll have to figure out the source. Do you have intrinsic factor, which can be done from an intrinsic factor test? If you do have intrinsic factor, you do not have pernicious anemia, but you can still have a B12 deficiency. And you probably have something wrong in your ileum. If there's nothing wrong with your ileum, your small intestine, and you're lacking intrinsic factor, either way, you have to take B12 as a sub-Q injection or an IV injection. So for either disorder, lifetime replacement of B12, but you can't take it orally because that's not going to work. Also, if your patient is on PPI, proton pump inhibitors, which we just learned about, proton pump inhibitors are H2 blockers for GERD. Those can reduce your your gastric cells from making intrinsic factor. So that is one of the side effects of a PPI or an H2 blocker. Long-term use is the inability to make intrinsic factor, and that can lead to a B12 deficiency. So if they do find a B12 deficiency and you're taking PPIs and H2 blockers and your intrinsic factor is low, they will probably stop the PPI or H2 blockers or reduce the dose so that you don't become B12 deficient or have that anemia. So again, take B12, but whether you can take it orally or through diet versus IV or IM, or they do have it nasal spray as well, you'll have to have some kind of non-oral supplement if you have a problem with intrinsic factor or your ileum. If you do not have a problem with intrinsic factor or your ileum, you can just eat away, and that will increase your B12 level. Folic acid deficiency is the other deficiency for large macrocytic anemias. Folic acid is also required for red blood cell maturation. It's used in babies for neural tube development, but in adults it is required for red blood cell maturation. If you have a folate deficiency, again, it's a folate level. If you have a low red blood cell, low hemoglobin hematocrit, and a normal iron level, and they look and see that you have a large macrocytic red blood cell, they will probably run a B12 level and a folate level and an intrinsic factor level to double check what's going on. If your intrinsic factor is okay, your B12 is okay, and your folate is low, you've got a folic acid deficiency. A folic acid deficiency, oops, we skipped too far. Oh, I didn't write. Where did that folic acid slide go? You give yourself folic acid. Ding, ding, ding. That's the intervention. I don't know what happened to the intervention slide. I'll have to add it back in. So your intervention is folic acid supplement. Okay. On to the next one. So we talked about the microcytic, the macrocytic. The microcytic was iron deficiency. Take your iron. Thalassemia is genetic. Stem cell transplant, blood transfusions if needed. Macrocytic is B12 or folate deficiency. Both of them, you need to take your B12 or your folate. B12 is complicated by the fact that you do need to run an intrinsic factor test and make sure that you have a working ileum. If you have intrinsic factor and a working ileum, you can have oral B12. If not, you'll have to have intranasal or IV or sub-Q B12. If you have folic acid deficiency, you take folic acid. Let's talk about the hemolytic anemias. The first one, hemolytic, means your red blood cells are lysing. The first one is sickle cell disease. And sickle cell disease is a genetic disorder where the hemoglobin is formed abnormally, carries plenty of oxygen, just fine, but if you're completely saturated with oxygen. If your hemoglobin does not stay completely saturated with 4 oxygens, then it pops apart. It like has a big drama meltdown and pops open and sickles. So if you're not carrying full amounts of oxygen, the cells will sickle. And then it's complicated by the fact that you're dehydrating. And if you're dehydrated, those sickle cells will clump up. So you can see here, this is a nicely hydrated vessel here. This is nicely hydrated vessels. Even though they're sickles, they're just floating along. They're not getting clumped up. But in a dehydrated area, this got clumped up because there wasn't enough fluid to flow it around and pass those sickled cells to a place where they can get degraded and broken up and recycled. So in dehydration, these sickle clumps get worse. So the first thing that happens is a decreased oxygen level causes them to sickle, and then dehydration can cause clumping. And clumping sickled red blood cells block the blood flow to certain areas and cause ischemia. So, when your heart blood vessels are having ischemia, you notice it right away as chest pain. The pain of the sickle episode, most of these are in small capillary areas, joints, extremities, and in the abdomen, in the GI system. That's where they like to clump up. They can clump up in the, we worry about them getting, yes, you can have a risk of pulmonary embolus, you can have a risk of kidney organs, but we put that in the worsening conditions. When you're having a sickle episode, most of the sickle episodes affect the joints and the extremities and the abdomen. So you have abdominal pain, you have finger, toe pain, and that is due to ischemia of the small capillaries. The defective erythrocytes need to be cleaned up, and so of course the spleen and the liver are overworked trying to clean up all these sickled cells as they circulate out. They're trying to pull them out of circulation. And the increased destruction of these red blood cells, because once they're sickled, they need to be taken out and recycled, creates excess bilirubin. So sometimes that's just more than the the liver can handle. And you get a little bit of jaundice because there's extra bilirubin that the liver isn't processing fully. So it kind of gets circulated around in the bloodstream. But that is the signs of a sickle episode, is severe pain, really, spleen and liver enlargement, and maybe some jaundice if the episode is big enough. If the episode goes on and gets worse, it's called a sickle crisis. This is coming with worsening hypoxia cues. Now we've got these sickled cells in our organs causing ischemia, so you can have kidney flank pain. Liver causes right upper quadrant and shoulder pain, and chest pain if it's getting into the heart. You can also have PE, pneumonias, strokes. You could have all kinds of problems with the sickle crisis. So what do you think, to stop this from happening? It started all in the problems with decreased oxygen level. So somewhere along the line, we had increased oxygen needs. Those oxygens got sent to the cells, and then the cells having a lack of oxygen, now sickle. So let's look at what we're going to do for our patients. The first thing we're going to do, and this kind of is in order, is we're going to aggressively hydrate the patient. We have to keep the blood circulating and avoid clumpings, because the danger of the sickle episode or the sickle crisis is the ischemia. So this will avoid ischemia. The sickled cells have already sickled. We can't fix that right now. You can't put a cell back. Once it is sickled, it is trashed, just like an activated platelet is trashed. So once the cell has sickled and you're starting to have pain, the big key is hydration, hydration, hydration. Keep those things flowing until they can get processed. Pain management is because the patient is having a great deal of pain with ischemia. Fingers, toes, abdomen are all hurting. You could also be having ischemia if you're in a sickle crisis. This has been going on for a while. You could have organ ischemia as well. The big thing for the patient to avoid oxygen consumption is rest. So we don't want the avoid body increased oxygen consumption. So resting the patient is important to preventing further sickling, okay? Rest decreases your oxygen consumption and reduces sickling. So we can't do anything about the cells that have already sickled. We need to hydrate, 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 keep them circulating until they can get processed. Pain management to manage the ischemia until we can get everything processing around. Rest. Stop doing what you're doing. Sit down and take a drink of water. When patients go into sickle episodes, which they do frequently, so maybe you're out trying to exercise or jog or do something that's requiring a little more oxygen than your body can handle, and you're starting to feel pain in your joints or in your abdomen, you need to sit down and rest. Stop the extra oxygen consumption and hydrate. You can get, if while you're at rest, you're still having low O2 sats or hypoxia, then oxygen is appropriate. But oxygen is not the first treatment here. Most sickle patients and sickle episodes know to rest and hydrate. The medicine that they can take is hydroxyurea. It basically firms up the red blood cells, decreases the breakage, allows them to carry better oxygen capacity. It reduces sickle episodes is the main key point of hydroxyurea. So it reduces sickle episodes. It's not going to solve it, not going to fix the problem, but it definitely helps the red blood cells cope a little better. Remember, these guys are just falling apart when they don't have enough oxygen, and the hydroxyurea kind of makes them a little stronger and reduces your sickle episodes. Keeping infections under control, treating them right away. This patient, as soon as they get sick, needs to rest and hydrate. It's a good idea for everyone, but a sickle cell patient needs to rest and hydrate. Rest and hydrate. DVT prophylaxis to reduce, and remember, DVT prophylaxis is going to be in the form of an anticoagulant. And what is it going to do? It's not going to prevent the cells from sickling, but it's going to stop fibrin clots forming on top of sickled. of sickled clumps. Well, you can write that better than I can. But anticoagulants will stop fibrin clots from forming on top of those sickled clumps. So if the sickled clumps kind of scrape up the red blood cell or scrape up the vessel, then of course it's going to send out stuff and it's going to activate platelets and create a clot. And then you're not only going to have a clump of sickle, but you're going to have a clot forming on top of that clump of sickle. So we don't want, I'm just going to go back and take the picture here. So we certainly don't want fibrin mesh forming on this guy. So if this scrapes up the vessel wall, then you might get basically a clot forming on top of this, and that will firm up those sickled cells so that it kind of keeps it from moving once you get hydrated. If we can get this hydrated, these things will stay in circulation. So if we can, our goal here is to get this hydrated so we get that moving and circulating around. But if a clot forms on top of it, it stays clumped up there and causes further ischemia. So anticoagulants, DVT prophylaxis is useful along with hydroxyurea, so that if you do go into a sickle episode and you do start having that clumping, that a clot doesn't form on top of the clumping and cause more problems there. The only cure for for sickle, most patients don't get a bone marrow transplant as a cure. They manage the sickle episodes, but bone marrow transplant is the only cure for sickle cell anemia. Again, these cells, this is a genetic condition. The cells are programmed badly. Not every red blood cell is programmed like that, but some of them get formed with bad hemoglobin molecules and have a tendency to sickle. So again, this is a genetic disease. Genetic counseling would be appropriate for these patients. It is predominant in African Americans, so it is a much higher risk in that population. Genetic counseling is important if any of the family members have had sickle cell disease. There's like 4 kinds of sickle cell disease, and they all vary in their severity, but just knowing it is a genetic disease. Adequate hydration at all times. The cells usually always sickle at some level. Keeping them hydrated and moving is the best way. Avoid crises. You're always going to have some kind of sickle episode. If you keep them hydrated, those sickle episodes, you just keep things moving around until the liver and the spleen can get rid of those sickled cells. But avoid crises. Recognize pain. Stop, rest, hydrate, and seat metal treatment if pain doesn't resolve. Exercise as tolerated, but stay hydrated while exercising. You will sickle as you exercise, so staying hydrated is the key. So this isn't something where you can go on your long run without your Camelback. Stay hydrated while exercising. Avoid infections and sicknesses. Use oxygen and create sickle episodes, so staying free from or treating infections, using vaccinations to avoid infections will be important. They have found that folic acid could sometimes help prevent blood vessel damage from the sickling episodes, which will prevent clots from forming on top of sickled clumps. So folic acid is helpful in terms of as long as DVT prophylaxis, folic acid and DVT prophylaxis will combine to make a very good way to keep you from, if you do sickle and you do clump, from forming a clot on top of it. Smoking decreases your oxygenation, so of course smoking in sickle cell disease will create more sickle episodes, more sickle crises. So definitely education on how to manage the disease. The only cure is bone marrow transplant, and that is quite a invasive intervention, but it is the only cure for sickle cell disease. So we'll talk about hemolytic anemias. Oh, and one thing I wanted to point out, too, on sickle cell disease, I do believe, one of the things we did say is organ ischemia back here. Most importantly, the kidney. The kidney is has very, those nephrons are itty-bitty, and sickled and lysed cells, I can't spell lysed. Is that even a word? Sickled and lysed? I don't know. But lysed and sickled cells do like to accumulate in the kidney, and the kidney will get rid of some of those extra sickles and lysed cells by peeing them out, but they can get stuck in the kidney very easily. So one of the first signs of a hemolytic, or not one of the first signs, sorry, it's a worsening sign. One of the first worsening signs is kidney pain from these lysed cells getting stuck in there. And the reason I mention that is because this hemolytic anemia, a straight hemolytic anemia due to, this is non-genetic, sickled cell is the genetic, non-genetic is usually from a transfusion reaction. You can also have some toxins that lyse your red blood cells. But basically, broken red blood cells lysing, they will create a hemolytic reaction. And that will give you chills, headache, fever, and this is basically what a blood transfusion reaction is. It's where your red blood cells are attacked by your immune system. So since your immune system is attacking these red blood cells, whether they're foreign red blood cells in a blood transfusion reaction or they're a toxin that's lysing your red blood cells, the immune system goes in there to clean that stuff up and will further lyse and degrade any damaged red blood cells. So when you're having a hemolytic anemia that's not a sickle cell anemia, this is caused by an immune system reaction. So you get the chills, the headache, and the fever because it is immune system, like a flu. When you have a flu, it's a super immune reaction. So chills, headache, and fever. The pain in the back, abdomen, and chest is the immune system eating up the red blood cells and causing lysed cells get stuck. These aren't sickled cells, they're lysed cells, so they're basically damaged red blood cells with white blood cells attacking them, and those get stuck in places. Pain in the back, abdomen, or chest is in the same kind of places as sickle cell, but in pain in the back is flank pain with the kidney. Hemolytic anemia reactions can cause pain in the abdomen. Pain in the chest would be if those damaged red blood cells and lysing red blood cells get stuck in the coronary arteries, get stuck in the, or happen at the infusion site. Hypotension, tachycardia, again, this is an immune reaction, so the immune system causes the hypotension and the tachycardia. Pink tinged urine is from the red blood cells the kidney trying to excrete these damaged red blood cells, and the rash and itching is from the immune reaction. Kidney failure can happen from a hemolytic anemia, just like kidney failure can happen with sickle causing kidney damage. We can cause kidney damage with hemolytic anemia. And because it's an immune reaction, you can have anaphylaxis with it. I'm just going to send you off to do blood typing. I'm probably not going to give you questions about blood typing, but I'm going to see if this blood typing game, let's see if the link works here. Go back. Let me see if the blood typing game works. The link didn't work the last time. Let's see if it comes up. You do have to have Flash. Flash was blocked. Manage, allow Flash. Let's see if that works. Blood typing game. Allow. So I don't know. You have to be on a computer. I don't think iPads play Flash. But this is a great game to learn your blood types and what goes with what. Fun game. We'll do a quick game. So hopefully you'll be able to play this. If not, I will send you the link and you just get on a computer and play it. But let's pick a guy. You get to draw their blood. And then you're going to drop it in. You're going to do the typing here. And you're looking to see if it reacts. So it did not react. So let's see if I can do this right. The patient is... let's see if I'm right. I did do it right. So it did not react with the A antigen. It did not react with the B antigen, so it's completely, the blood that you put in there, the A didn't bother it, the B didn't bother it, but it did react with the Rh factor, and so you are Rh positive. Let's do another one. So O positive. And then you get to decide what blood to give it. So you know O positive can get O positive. And he's happy. If you give him something he can't have, so O blood cannot have anything other than O blood. It can't have B blood because it recognizes B blood as a bad blood. It only recognizes itself. So you can see it gets freaks out. I love playing this game because it really helps set all this in motion. But if you look at the 4 types, there's A, B, AB, and then O. You see how O has nothing on it? So it will see A is for, oops, let me go back. It will see A is foreign. It sees B is foreign. It says A, B, and foreign. It'll only recognize type O, okay? Because it doesn't recognize anything else other than a smooth, silky smooth outside layer. A blood only recognizes A blood, and then O blood doesn't have anything on it. It's like, I'm kind of chill with O blood. O blood can go anywhere. There's nothing reactionary on it. There's no A little antigens. There's no B antigens. There's nothing on it. So O can go to anybody. A likes O. B likes O, because when B sees this blood, it doesn't see anything that it needs to fight. It doesn't quite look like itself, but it's not kind of scary. It doesn't see anything unusual on it. So O can go to anybody because it has no reaction, no antigens on it at all. It's completely unreactionary. B only can go with B. It does not recognize A. It does not recognize those triangles, man. It is not chill. B can only go with B. B can't go with O because O will kill it. O only recognizes anything. It thinks anything else on the outside is evil. So O doesn't recognize A, doesn't recognize B, doesn't recognize AB, will fight it. A recognizes itself, and it will take O because he's like, well, I mean, there's no triangles on you, but at least there's no circles. So you can come on in. So A can take A or O. B can take B or O. AB, it recognizes everybody. Look, it's got triangles on it. It's got circles on it. It recognizes everybody. AB can take anything. Y'all can come in. AB is the universal recipient, and O is the universal donor. Then that's complicated by the Rh factor. Rh positive people can only get positive blood, and they can get negative blood. Because Rh, if you don't have the Rh factor, then you're Rh negative, and negative blood can go to any positive person. Positive blood can only go to a positive person. So if you go to the blood typing game and play it, you'll have a great time. You'll just learn how to start recognizing them, and like I said, play it. It's a fun game. Your kids can play it. You can study with your kids. But basically, let's try. Let's see if we can get somebody who has a difficult one. So this reacted with A, did not react with B, reacted with the Rh factor. So it is A positive. Ooh, 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 yay! So you can go play with that, and then once you decide that they are A positive, you get to decide what blood they can have. This patient, well, can definitely have A positive. They can have A negative, and they can have 2 other kinds. Well, you know A doesn't recognize B, A doesn't recognize AB, so nothing with B in it. But you know what? That O was nice and silky smooth, and they were positive. So you can, if you forget, you can see your blood type's positive. So they can have the positive factor, and they can have the negative factor. Yay, you did it. So I'll let you play it. It's really fun. Man, I'm gonna do one more. Oh, it's the same one. Board A positive. Let's see if we can get another one. Let's give him something. A positive can have A positive, A negative. Let's give him some B. Oh, he did not like that. O positive. O negative. Okay. So anyway, I'll let you, like I said, play this. It keeps recycling it and giving you different blood types every time you play it. Don't give me A positive again. Ooh. What do you think? Reacted with A, reacted with B, so it's AB, and it reacted with RH, so it's AB positive. See, now you can go work in a lab, right? And then you got to decide, what can your AB positive patient have? Well, that's an easy one. They can have AB positive. Since they're positive, they can have the negative factor too, because that's not reactionary. So which one do you think they can have? Can they have A? They can have A. Can they have B? They can have everything. So, anyway, you can replay it as much as you want. Have fun with it. Have fun with the kids. You'll enjoy it. So that's really, I mean, I'm not going to test you on the factors, but I think they're fun. So if you have a transfusion reaction, you're not giving them something that they can have, you'll see that you're going to have a risk of fever, chills, back pain. Back pain is flank pain due to kidney problems, abdomen pain, chest pain, and then a severe allergic reaction or an anaphylactic reaction. And the pink tinged urine comes from the lysed cells getting excreted by the kidneys. What we're going to do with it is, of course, remove whatever's causing the hemolysis, stop the infusion of blood products, give a steroid to dampen the immune response, and aggressively hydrate the patients to flush the lysed cells and reduce the risk of kidney injury. Pain management, if they're having any pain from any lysed cells getting stuck somewhere. Rest with DVT prophylaxis. Again, DVT prophylaxis keeps fibrin clots from forming on areas of lysed cells. So that is hemolytic reactions. I'm going to go ahead and stop this one, and I will record a separate lecture for thrombocytopenias.